Clinical presentation of SARS-CoV-2 infection. During the entry of the virus into the body, the virus may remain in an eclipse phase for few hours. This is soon followed by a phase of high viral shedding and replication. The viral load starts coming down by second week of illness and majority of the patients recover. Few may develop altered clinical course with worsening symptoms and complications. Thus, the clinical phase can be classified into an incubation phase, prodromal phase, acute phase, and a convalescent phase. Thus, symptoms in the early part of the illness is related to viral replication, whereas in the later part is predominantly related to a dysregulated host response. Soon after the viremia, the body starts to produce antibodies, which peaks about 4 weeks post-illness. Initially, it results in an IgM response followed by an IgG response. Clinically, it can be classified into pre-symptomatic phase and a symptomatic phase. Pre-symptomatic phase is the time period between exposure to virus and symptom onset. It is same as incubation period, which is 5 to 14 days. The person may be infectious during this period, however, data on this aspect is limited. Asymptomatic phase is nothing but pre-symptomatic phase in a PCR positive patient. They are usually identified by family screening or contact tracing. The common symptoms include fever, cough, sore throat, generalized malaise, loss of smell or taste, and shortness of breath. Other less common symptoms include headache, nasal discharge, rash, altered sensorium and stroke, nausea, vomiting, and respiratory distress. Coronaviral disease is a multi-system disease that affects almost all organs of the body. The most common that gets affected is the respiratory system, which can manifest as cough and sore throat, and in those who have progressive illness can develop pneumonia and ARDS. Effusions, consolidation, and pneumothorax are unusual in SARS-CoV-2. The next most important organ that gets affected is the cardiovascular system. It can range from myocarditis, pericarditis, heart failure, myocardial infarction, and thromboembolic events, and also, in rare cases, stress cardiomyopathy. Neurological manifestations like stroke, demyelination, ataxia, meningoencephalitis-like presentation, Guillain-Barré syndrome, and optic neuritis have also been reported with SARS-CoV-2 infection. Gastrointestinal manifestations are more common in pediatric age group and can present in the form of nausea, vomiting, diarrhea, abdominal pain, and hepatitis-like. Increasingly, episodes of hyperglycemia and adrenal insufficiency have also been reported with SARS-CoV-2. The common dermatological manifestations observed are an exanthematous rash or a papillosquamous eruptions. Perineal foot or COVID toes and livedo reticularis are rare manifestations of SARS-CoV-2. Children are usually asymptomatic in up to 50% of cases. In those who become symptomatic, majority of their symptoms are mild. Fever is usually low grade, but if it is high grade, one need to consider MIS-C or other non-COVID related causes. Family contact is usually present in the case of COVID infection in children. For any communicable disease, for the purpose of case definition, they are classified into suspect, probable, and confirmed cases. We will now look at the WHO case definition for SARS-CoV-2 infection. The clinical criteria include acute onset of fever and cough, or acute onset of any of 3 or more of the following as fever, cough, generalized weakness, headache, myalgia, sore throat, coryza, dyspnea, anorexia, nausea, vomiting, and altered mental status. Severe acute respiratory illness or SARI is defined as acute respiratory infection with history of fever of more than 38 degrees Celsius and cough with onset within last 10 days and who require hospitalization. In those who fit into the clinical criteria, if anytime within the 14 days before symptom onset, if they were residing or working in a setting with high risk of transmission, or if they are residing in or traveling to an area with community transmission, or if they are working in a health setting which includes health facility, they have an epidemiological link for SARS-CoV-2 infection. A suspect case is a person who meets the clinical and epidemiological criteria, or a person with severe acute respiratory illness. A probable case is a suspect with inconclusive RT-PCR, or a suspect in whom RT-PCR could not be performed, as in cases of demise prior to testing. Confirmed cases are those with a positive nucleic acid amplification test, or a person who is positive with rapid SARS-CoV-2 antigen test and meets the case definition for a probable case. Close contacts are face-to-face contacts in any setting with a confirmed or a probable case within 1 meter for more than 15 minutes duration in the period extending from 48 hours before the onset of symptoms. Sharing a close space for a prolonged period of more than 2 hours can also be considered as a close contact. Severity of COVID pneumonia can be classified into asymptomatic when they are PCR positive but they do not have any symptoms, mild if they have symptoms but no tachypnea, moderate if they are tachypneic with or without chest indrawing but do not have hypoxemia, and severe when they are associated with hypoxemia or any danger signs, and critical when they have multiple organ dysfunction. Mild disease is characterized by sore throat, rhinorrhea, and cough. However, there is absence of fast breathing. Moderate disease fits into the definition of pneumonia, where there is fast breathing as per age-based respiratory cutoffs of more than 60 per minute for less than 2 months, more than 50 for 2 to 12 months, more than 40 for 1 to 5 years, and more than 30 for beyond 5 years of age. Severe disease is defined as severe pneumonia with cyanosis, increased respiratory effort in the form of grunting or severe retractions, lethargy, somnolence, or seizures. Critical disease is characterized by organ dysfunction like ARDS, septic shock, acute thrombosis, MIS-C, or multi-organ dysfunction syndrome. The common risk factors for severe disease include a very young age and a very old age, chronic lung disease, asthma, congenital heart diseases, immunocompromised state, obesity, diabetes, chronic liver or kidney diseases, poor nutrition, and smoking. The overall case fatality rate is about 1% and the case fatality rate in children is about 0.1%. The case fatality rate varies according to age and sex. It is lower in younger people between 45 to 65 years and higher in those over 75 years of age. Milder disease do not require any specific intervention. However, severe COVID pneumonia may require intensive care support. Usually, most of the symptoms, even in severe COVID, tends to resolve over a period of 4 weeks. Long COVID is a situation where these symptoms persist beyond 4 weeks of duration. Long COVID is a post-COVID syndrome after recovery. It is defined as persistence of symptom or development of sequelae beyond 3 to 4 weeks from the onset of acute symptoms of COVID-19. It can be subacute or ongoing symptomatic COVID-19 where the symptoms or abnormalities are present from 4 weeks to 12 weeks beyond acute COVID-19 infection. Or it can be chronic or post-COVID-19 syndrome where the symptoms or abnormalities persist beyond 12 weeks of onset of acute COVID-19 and are not attributable to alternative diagnosis. The most common cardiorespiratory sequelae noticed is dyspnea or persistent oxygen need. Majority of these patients may need a 6-minute walk test, a PFT, chest X-ray, echo, and CT during their follow-up. The incidence of thrombosis at 30 days following discharge has been noted to be about 2 to 5% based on preliminary evidence. This area needs more research as extended thromboprophylaxis may be needed in high-risk survivors. In those patients who have COVID-19 and acute kidney injury, They have to be assessed for recovery of acute kidney injury during their follow-up. Early follow-up with nephrologist is advised. Neurologically, they may have anxiety, depression, post-traumatic stress disorder, sleep disturbances, and cognitive impairment. All patients need to be considered for early rehabilitation with patient education and involvement of patient advocacy groups. Thus, a multidisciplinary team approach is needed during rehabilitation of long COVID patients. If you like these videos, subscribe us and follow us for new updates.